Hello, and welcome to the symplr Education Series webcast. Today's webcast is titled Credentialing, Recredentialing, and Privileging Basics with guest speaker Kathy Matzka. At the end of this session, we will have time for a formal Q&A, but feel free to ask any questions as they come to mind via the chat box located on the right side of your screen. You will also be able to download the archive of today's webcast and its slides at symplr.com soon and will receive download information in an email. This CE certified webinar is sponsored by symplr Compliance and Credentialing for Healthcare. We are so pleased to have Ms. Kathy as our speaker this month. Kathy is a speaker, consultant, and writer with 30 years experience in credentialing, privileging, and medical staff services. She holds certification by NAMS in both medical staff management and provider credentialing, and is one of the first recipients of the NAMS Fellow designation. I'm sure many of you know her, and I'd like to turn it over to her now.
Thank you very much. Okay, so what we're going to talk about today is some basic credentialing concepts. And so this is going to be like Credentialing 101 type of a discussion here. So this is for new people that are new to credentialing and privileging, as well as can be a refresher for those more experienced people as well. So we're going to just do a brief overview of credentialing and privileging. We're going to talk about federal regulations, those CMS regs, and we're going to talk about primary source verification, using appointment and privileging criteria, red flags that you may find in the application process, the roles and responsibilities of various people in credentialing and privileging, and then we're going to talk about documenting recommendations, how to document all that work that you've been doing during that credentialing and privileging process. So the difference between credentialing and privileging is credentialing involves verifying a practitioner's credentials. So by that we mean verifying that they are who they say they are, that by looking at their ID. We look at their medical school, verify that they did attend medical school, that they did go to the training programs that they've listed on their application, and that they completed those appropriately, and that they were trained to do the things that they want to do at our facility. And we also verify peer recommendations, right, to people who have worked with that person and can verify that they are who they say they are and that they're competent and qualified. So that's the credentialing piece of it. Privileging is a little more complex than credentialing, and that's where we document those types of procedures or the privileges that someone is able to do at our organization. And then we document we use the credentialing information we have to document that they meet that eligibility requirement for those privileges. So another piece of privileging is evaluation of that care and making sure that they really have been performing the procedures that they want to do at our facility, and that they're doing it in such a way that it's a high quality and there's that they're doing a good job with the things that they want to do. So when we look at credentialing and privileging, they are two separate processes, but they do work together. Like I said, the credentialing is used to determine whether or not that person meets the privileging criteria that has been established. So why do we do credentialing? Well, the number one reason we do it is to protect patients. We want to do everything we can to make sure that those people who are providing care in our facilities, or for our managed care plan, or for our health care, our medical group, whoever you're credentialing for, we want to make sure that those providers really are who they say they are, and that they really are qualified and competent to do the things that they want to do, because we want to protect the patients that we have coming into our facilities. And the other thing is we have this risk management issue of negligent credentialing. And if a provider injures a patient through an act of negligence, the organization can also be found, can be charged or alleged that this organization is negligent in credentialing that provider. So if it's found that the organization did not meet those basic that the standard of care establishes for credentialing and privileging, the organization can be held separately liable for negligently credentialing that provider. One of the things we see with these negligent credentialing claims is that in some states, the tort limits that apply to medical malpractice claims do not apply to negligent credentialing issues. So you'll see that there are plaintiff counsels who will look at the record and see if there's a reason that this provider may not have been the best person for your organization to credential. And they may also, in addition to having a medical malpractice case against your facility, they may also have an allegation of negligence in credentialing or negligent retention. The other reason is because there's accreditation and regulatory requirements. If we don't meet those requirements for credentialing and privileging, we're not going to be able to be accredited by the Joint Commission or HFAP or DNV, or we're not going to be able to pass our state surveys. So we have to be able to meet those minimum requirements in order to meet those accreditation and regulatory requirements. When we're looking at the application, it's important to determine that each question is answered legibly, that you can actually, not just that there's something written in there, but you can actually read what's written in there. I can remember one time having a doctor who checked off the box in between, it checked off right between the two boxes, and the question was whether or not there had been any disciplinary action or suspension of privileges at another facility. And instead of checking yes or no, the doctor checked off in the middle of the two boxes. And I called and asked him why he did that, and he said, well, I had a medical record suspension, so I did get my privileges suspended for not completing my medical records, but I didn't know if that was what you were looking for or not, so I just put the box, checked it in the middle. So you need to make sure that there's, if there's something that you can't read or you're not sure about, that you do clarify that. The application needs to be signed and dated. The attestation needs to be dated. Signed. The consent and release form needs to be signed and dated. And we want to look to make sure that there's no unexplained time gaps since the time they completed their medical or professional school. And when I talk about unexplained gaps, I mean time frames where there's nothing that references where they were during that time. Now, we're always going to see gaps because people, especially nowadays, people take family medical leave. They may, someone might take off a maternity leave. You'll never, as long as there's an explanation for where they were during that time, a gap in itself is not a problem. But you want to make sure that there's nothing that's unexplained. When I talk about a complete application is one that has everything there and it's ready to go to your first level of review. So it needs to be defined by your bylaws or a medical staff policy what a complete application is. Usually bylaws will have some kind of language in there saying what things need to be complete, what things need to be provided along with an application. So there needs to be no blanks. All attachments are present. When I talk about no blanks, I mean that there's no sections that are not filled out. Now, I do understand that there are some states, like for instance the state I live in Illinois, that have a standardized application. And the information that's on that application, not all of it is relevant in a hospital. Some of it is more relevant to a managed care plan than a hospital. So your medical staff can define in a policy, if you have one of those standardized applications that are required for your state, your medical staff can define what pieces of that application have to be completed in order for it to be considered complete. For example, your application in Illinois has information about office hours and whether you have bilingual staff working in the office and so forth. That may be something that as a hospital you may not be interested in. So that section there, if that's blank, you would not consider that an incomplete application. So you determine in your medical staff policies or bylaws what is a complete application. Also, we want to make sure that there are no unexplained gaps, and that also a part of having that application complete is that all the information that you sought, all those verifications have come back. So that means that you verified the licensure and the medical malpractice claims, and all the peer recommendations are back, and all the facilities that you've written to have sent their information back. All that information is back, and there's no inconsistencies identified. So for example, if you get a letter back from a hospital and it has different verification date, different dates on it than what the person put on the application. That would be something that you would want to clear up before that application is considered complete. And then having documentation of current competency is another thing that needs to be there. Every set of bylaws I've ever read have had some kind of language in there about the application the applicant needing to document that they're currently competent to do the things that they want to do. So you have to make sure that you have that information for that complete application. And keep in mind that even though it's the medical services professional that knocks themselves out to get all the application completed and get the information in and send out the letters and so forth, the burden of proof for getting that application complete is on the applicant. And it's the applicant's responsibility to make sure that you have everything you need in order for your medical staff to go forward, or credentials committee to review that application. So the burden of proof is on the applicant. What I usually recommend to my clients is that you give it at least 2 tries. You send out 1 letter and a follow-up email, or 2 emails, or a letter and a phone call, whatever, 2 tries. After 2 tries, your 3rd call goes to the applicant and you say, I've tried 2 times, now it's on you. Please, follow up this reference and ask them to get that information into us. So within a hospital, the credentialing process is spelled out in a number of places. The bylaws usually establish a framework for what the process is, and it's usually something that says something like if you're a departmentalized medical staff, it'll say the department chair reviews it, and then it goes to a credentials committee, and then the MEC, the medical executive committee, and then off to the board. So that's usually spelled out in there. But then rules and regulations may have additional requirements. So, for example, your bylaws might have a requirement that says that in order to be on staff that you have to have completed an ACGME approved medical school and training program. But you may have additional requirements in rules and regulations. So, for example, you might have the Department of Obstetrics and Gynecology might have a requirement in order to be granted privileges that you have that you are board certified, or that you achieve board certification within 3 years of completion of your training, or some language like that. So even though there's some information in your bylaws and rules, and there may be additional in your rules and regulations. And then we have policies and procedures. So policies and procedures typically spell things out in a lot more detail. So your bylaws might say something like the applicant has to submit evidence of a current licensure in this state to be able to be granted medical staff appointment. Your policy and procedure might go further. You might have something that's defined that says, as part of your credentialing process, we will verify licensure by going to the state board's website and verifying that that the license is current. If it shows that there's any disciplinary action, then an additional request will be made in writing to the board to ask them to provide any additional information that may be available because of the disciplinary action that was taken. So you may have spell out in a lot more detail in a policy and procedure how that actual credentialing process is accomplished. And this is one of the biggest problems that I see as a consultant when I go to hospitals, is that there's one person in the facility that knows how to do the credentialing and privileging, but it's all in their brain. Nobody has written down a policy and procedure. So when something happens to that person where they have to go out on medical leave, or you have an appendectomy, you don't plan these things. If something like that happens, then there's no one else in the facility that knows how to process an application, do a data bank check, verify a license, or anything like that. So it's a great idea to have policies and procedures that spell out how to do each step in that process, so that if something happens to the one person who knows how to do it, then someone else can step in and take over. The hospital conditions of participation are the Centers for Medicaid and Medicare Services requires that you follow the CMS conditions of participation if you want to take care of Medicare and Medicaid patients. So all the interpretive guidelines and manuals are all available on the CMS's website. The information that's on there is the same information that the surveyors use when they come and survey you. It's the same interpretive guidelines and the same regulations that they use. It's not secret. You can download them. The links that you have here that you can see here are the most recent ones for both a hospital and a critical access hospital. And you can see the hospital ones haven't been revised since the end of 2015, but there was a recent change in the critical access hospital regulations, but that didn't reflect on the credentialing process. So keep in mind that if this link, even though the standards change and there may be a different revision, the link that you see there on the on your page will still work. The link stays the same regardless of whether or not there's a change. Anytime there's changes that are recommended by the regulators, they publish those changes in the Federal Register. So, and the information for the Federal Register is also there on your page. If you're interested in seeing what changes are posted, you can sign up on the Federal Register's website to get email notifications of each. It'll give you the table of contents for that today's edition of the Federal Register, and you can look down and see if there's anything under Medicare, Medicaid services, and that way you can keep up with current changes that are published. The Medicare conditions of participation for both hospitals and critical access hospitals require that there are criteria that are established for determining privileges and that a mechanism for applying that criteria. What they require that is looked at for each practitioner who's going to be granted privileges is that you look at that person's character, competence, their training, their experience, and their judgment. So these are specific things that every hospital that treats Medicare patients has to look at for every applicant. There's also some requirements for identification and review of credentials, and this includes that they have to have a request for clinical privileges. Usually that's our privilege form that they fill out, that there's evidence that they are currently licensed. And when they talk about current licensure, they do not mean that you have to verify license in every state in which the person has ever had a license. What they mean is that they have current licensure to provide services in your state where they're providing services to your patients. That you have to have evidence of their training and professional education, their documented experience, and supporting references of competence. The most difficult thing that we have to get when we're credentialing is that documentation of experience. It's really easy to go online and verify a license, but it's harder to get that documentation of experience and competency. Primary source verification is information that we get directly from the source that issued the credential. So when we talk about primary sources, we look at licensure boards are the ones that issue the license. So we go directly to the licensure board and we verify it. That licensure board is the primary source. So it can be done in a number of ways. You can do it in writing a letter. You can do a telephone verification, faxes. You can use websites. Any of those are acceptable ways of doing primary source verification. And we want to do that primary source verification because we don't want it to come from someone else. We want to ask the source that gave that credential if it's a valid credential. There's a number of different ways that we can accomplish primary source verification. As we can do it ourselves within your facility. It can be done by a credentialing professional in facility. You can have a centralized credentialing office that's located, as part of your healthcare organization. You may have, 2 or more hospitals, but just one place is delegated to do all the credentialing, and then they do it one time for all the facilities. You can also delegate the primary source verification so that you can have another organization that you have a contract with to delegate that performance of that credentialing to another organization. You can delegate the credentialing, but you cannot delegate the responsibility for making sure that it's done correctly. You're still going to be held responsible for making sure that you have all the information that's required by your accreditation and regulatory requirements. Now, sometimes we can use other sources rather than writing to the primary source. So there's some things called sources called designated equivalent sources. Sometimes they call them secondary sources. It just depends on what accreditation standards you're reading. And these are agencies that are determined to maintain items of credentials information that is identical to the information that's at the primary source. So an example would be the American Medical Association physician profiles. That physician profile service, all the ACGME accredited training programs and medical schools send their information to the AMA for that provider profile. So that provider profile can be used as the designated equivalent source rather than writing to the medical school or the training program to verify completion of that program. A primary source can also designate another organization as its agent in providing information to verify credentials. And another example, again, is the AMA physician profiles. The American Board of Medical Specialties is the organization that keeps track of all of the board certifications for all of the different subspecialty boards. So the American Board of Medical Specialties designates the AMA profiles as their display source, their designated display agent for the board certification information. So you can actually use an AMA profile to verify board certification for those member boards. When you're looking at individual elements, the things that we look at, we talked earlier about education and training and experience. Work history is another thing that many people will evaluate, whether or not where they went, what hospitals they went to, if they were on staff at ambulatory care facilities, and there's verifying that work history. It's up to the organization or your medical staff to determine how far you want to go back with that. Some organizations will verify work history and hospital affiliations going back to the time that they completed their training program. Other facilities may go back just 5 years or 10 years. They will collect all the information, but they may only verify going back 5 or 10 years. And it's up to the organization to determine, their medical staff, what they feel is relevant. If you're looking at just current competency and whether or not someone is currently competent to do the things that they want to do at your facility, then a verification letter that's 10 or 15 years old is probably not going to be reflective of current competence. So you have to determine, medical staff has to decide how far back do we want to verify work history and hospital affiliations. Peer recommendations is another thing that we use. We have peer recommendations that we ask for the provider to include on the application. And peer recommendations, we like to see people who are currently knowledgeable about that applicant, and at least one person typically we like to see that is in a supervisory role that can provide information about how that person did. You don't want to have somebody giving their wife, who's also a doctor, as a peer recommendation. You don't usually want family members. Some organizations will not allow partners to give peer recommendations. Some organizations will allow, will say that has to be somebody who you are currently on our medical staff. So it just depends on how your medical staff bylaws and policies and procedures are worded, what is going to be an appropriate peer recommendation at your facility. There are some sample letters that are included in your handout. And there's some on education. There's one for your training. There's one for your training program. There's one for writing to other facilities, and there's a sample peer recommendation form as well. One thing I want to mention about the training program form is that there's a group of people got together and determined that there was what needed to be included, and I'm going to pull this up here. The sample letter for verification of training. So what happened is the ACGME, the American Hospital Association, the NAMS organization, and there's an organization of program directors got together, and they came up with a standardized verification of graduate medical education program training tool. So what they're doing is now whenever you write to an organization to determine whether or not someone completed their medical training there, you're going to get back this form. So the form is going to be completed at the time someone completes their training program. The program director will complete the form and put it one time, put it in that practitioner's, that trainee's file. So anytime after that they get a verification letter, you're going to get that copy of that form that was put in that trainee's file. For people who completed their training prior to 2016, they're going to complete it one time when that program gets a request for verification of training. So what's going to happen then is the current program director is going to review that person's file, and they're going to complete the form based upon the information that's there in the record. And then they'll put a copy of that completed form in there, then every subsequent letter that they get is going to get that same form. So this is the letter that the cover letter that you would send to the residency program director, and this is the letter that would come back from them where they say it was completed at the time they left the program or by the current director. And then there's a verification of training that this all will be filled out by them, whether or not there's any kind of disciplinary actions. Did they demonstrate sufficient competence to be able to practice without supervision when they completed the program? And then there's a place for additional comments. So this is going to be what you're going to be seeing at the time of you get those letters back. So if this is the letter that they're going to use, you might as well just consider utilizing that form letter yourself when you're doing your when you do your verification letters. The copy that you have in the Word program there, the Word document, you should be able to cut and paste and upload into your credentialing software or your Word document, however you're using it. Board certification is another thing that we want to verify. If you require board certification, if you don't have a bylaws requirement that says that they have to be board certified in order to be granted privileges or to be granted medical staff appointment, then there's no law or rule that you have to verify board certification. But if you do have a requirement that somebody is board certified in order to get medical staff appointment or to be granted privileges, then you do have to verify that board certification, and you do have to follow up and make sure that you are, that they continue with that board certification. Sometimes there's organizations that are just difficult to reach. They may be closed, and when that happens, you might want to consider using some secondary sources. This can be something like a written statement from somebody who is is a successor organization, somebody who took over that facility, or maybe a leader that was there at the time, the president of the medical staff that was there at the time, but now they've, the place is now closed. You may be able to find that person and be able to write to them. If you get back a letter from them when you send it and it says this hospital is closed, another thing you can do is call another hospital that's in town, ask them if they know who purchased that hospital, if they know where the records went. So you can also maybe utilize another hospital that might have documented primary source verification of that applicant's credentials. So if the doctor tells you, well, that hospital's closed, but at the same time I was on staff at another hospital that was in the next town, you might be able to contact that hospital, the other hospital that he was on staff at, and ask them if they had ever done primary source verification of the closed facility, and ask them if they'll share that with you. If they won't share it with you, they may share it with the provider, the applicant, and then that applicant can provide that information to you. Another thing that we need to verify is sanctions and disciplinary action. We have to look and determine whether or not there's any disciplinary action on the person's license. And I mentioned earlier when we were talking about policies and procedures, when there's a licensure disciplinary action, we want to go to the state board and find out all the information we can about that issue. When you go onto the website and you see that there's a disciplinary action and you click on the little link and it tells you that, and you're able to download a consent order or something like that. It took a lot of paperwork to get to that consent order. There's a lot more information that may be available to you from the licensure boards, either through a Freedom of Information Act request or through the applicant signing a consent and release form for you to get that information. So it's a good idea if you have somebody who has a licensure disciplinary action that you do follow up with the state licensure board and get all the information that you can regarding that issue. We also want to look at the Office of Inspector General's list of excluded individuals and the Systems for Award Management, which is SAM.gov. The OIG list includes people who are excluded from Medicare, Medicaid, and federal health insurance programs. The System for Award Management is anybody who's excluded from any kind of contract with the federal government. So it may be somebody who was working for some aerospace industry and was excluded because of some problems with contracting, and they're not able to have a government contract, so they may be listed there as well. So look and make sure that they're not excluded from OIG, in OIG, or into the System for Award Management. These are both free resources that are available to review. And this is not part of really credentialing per se. It's really a corporate compliance issue. The problem is if there is a disciplinary, somebody is sanctioned and they're excluded from Medicare, then you're not going to get paid by the government for any of those services that provider orders or any treatment that is done at the facility. So you have, you need to be monitoring this database on an ongoing basis. They update it every month, and just make sure that your providers are not excluded from Medicare, Medicaid. We also verify their liability history, proof of coverage. We like to look and see what kind of claims or at a minimum final settlements, judgments were made on that provider's behalf. We can get that either through the insurance company. If we want outstanding claims, you can get it right through the insurance company. Closed claims are usually you can get from the, and settlements or judgments that were made on behalf of that provider would be, of course, in the National Practitioner Data Bank reported there. But it's the, writing to the insurance company and asking them to provide a claims history or a loss run and using that as part of your credentials file. Also, we want to make sure that they really are covered. That we want proof that they're covered at your facility under their medical malpractice. So we also write to the insurance company and verify that they truly are covered. We look at their health status or ability to perform procedures. We usually ask them to attest that their health is such that they can provide safe, effective patient care, or whether or not there's any kind of accommodation that they may need. In some cases, an organization may require a physical exam. I've seen organizations that required you to either submit a statement from your primary care doctor that your health is such that you can safely and effectively perform your patient care responsibilities. And I've also seen organizations that required physicians to go to their, a hospital, a physician that the hospital or organization has designated as their provider for doing these types of physicals. Sometimes it's an employee health physician or just someone that they have an agreement with. Making sure that someone is who they say they are by verifying the identity is also very important. We want to make sure that the person who is showing up in the emergency department for the midnight shift on Saturday night, the locum tenens doctor who's filling that shift, that there's somebody there that's verifying their ID and making sure that they are who they say they are. If you're a Joint Commission accredited facility, there is actually a requirement for verification of identity, and that somebody is actually viewing an ID to verify that identity prior to the time that they grant, that they are providing any patient care within your facility. So there's, again, a sample policy and procedure that's included in your documents that is just a way of, meeting that requirement as far as verification of identity. Okay, let's switch gears here a little bit. Now we're going to talk some about clinical privileges. And remember, privileging is the process we use to identify and document and approve any kind of specific procedures and treatments that they can perform at our facility or that specific setting. And back in the old days, only admitting privileges were granted, and this was only granted to physicians. We didn't have advanced practice nurses and PAs and all of these other ancillary staff providers that were admitting patients and providing patient care. Fewer treatment options were available back then, so most practitioners, when they got out of their training program, I'm going back here into the 50s. So back then there were, we didn't have all the subspecialty programs. We had, a surgery training, we had medicine training, and then, family medicine and surgery was kind of what we had back then. So people that completed those training programs, there were fewer options available, we didn't have the technology and equipment that we have now. So the people that got out of those training programs could pretty much competently perform most things. But in the 1950s, the American College of Surgeons, they recommended what we call the laundry list approach. And this is where you just list all those types of procedures. But because at that time, there were a lot of physicians who hadn't completed residencies. So you could do maybe a one-year internship, and you could start working in a lot of states. When I first started working in medical staff services in the 80s, we had physicians at that time on staff at the hospital I worked at that did a one-year internship in general internship, and they were working. So as family medicine doctors. So, but so the skill sets varied. So they started, technology kept advancing, and hospitals started establishing these lists of all procedures that could conceivably be performed, and it can be rather burdensome sometimes because technology is always changing and new procedures are always being added. So today, privileges are granted within an area of practice. That means that if you are a general surgeon, you get general surgery privileges. If you are a vascular surgeon, you get vascular surgery privileges. So they're granted within a more narrow area of practice, and they're not a right. So the person who is applying for those privileges has to prove that they're qualified, and we do this by making sure that they have the appropriate documentation of their training and their experience and their clinical competence. The Medicare conditions of participation in the interpretive guidelines under the medical staff has a statement that says that it cannot be assumed that every practitioner can perform every task, activity, privilege that's specified for that applicable category of practitioner, and that individuals' ability to perform each task, activity, privilege must be individually assessed. So what they're saying here is that if you have a list of all these types of procedures that are included on a form, you can't just assume that just because somebody completed a minimum training program that they can do everything that's on there. You have to assess their ability to do those things. So within a critical access hospital, there's some little bit different language. It says that the medical staff bylaws have to include the criteria for determining what privileges are going to be granted and a procedure for applying that criteria. There also is a requirement about surgical privileges that they're granted in accordance with the competencies of each practitioner. So what they're saying here is that if someone wants to have privileges to do a surgical procedure, you have to determine that they're competent to be able to do that. Then they require also for the critical access hospital, there's some language that says that the appraisal procedures that are used by the medical staff has to evaluate their training, education, experience, and demonstrated competence. Remember when we looked at those CMS regs earlier and they talked about the same thing for the hospital, having the training, education, experience, competence, all those things have to be evaluated for a critical access hospital as well as for an acute care hospital. And they expect that you evaluate that through your QA program, your credentialing process, making sure that those practitioners adhere to all your quality, your policy and procedures that you've established, and also that they're functioning within that scope of practice that your state has defined. For both the hospital and the critical access hospital regulations, the CMS the regulations say that surgical privileges have to be reviewed and updated at least every 2 years. Now, you probably noticed that or you may have, that I haven't said that the CMS regulations require that you reappoint people every 2 years. They really do not specify that. What they say is that that the medical staff has to evaluate the practitioners on a periodic basis, and they recommend in the interpretive guidelines, it says it's recommended that it be done at least every 24 months, but a recommendation is not a regulation. So even though it's recommended that it be done every 24 months, there are hospitals, for example, DNV accredited hospitals that can recredential every 3 years. Unless the state requires that it be done more frequently. But even if you do that, you still, if the person has surgical privileges, those surgical privileges have to be reviewed and updated at least every 2 years. There's also a requirement for both hospitals and critical access hospitals that there is the surgical suite, and any place where surgery scheduling is performed has a current roster of everybody knowing what their privileges are and that they have these surgical privileges. And they also have to have a suspension or restriction list available. So if somebody has their privileges suspended, for example, for not getting their medical records done, or they haven't renewed their medical malpractice insurance and they have an automatic suspension, then the surgical suite in any place surgery is scheduled has to be notified of those suspensions or restrictions. There's a number of different ways of documenting privileges. Privileging systems are all over the board. You can do it by categories or levels, where you put group procedures in categories based upon the skill level it takes to complete those procedures. You can have those lists or laundry lists that are just checklists that you just check off each individual procedure. You can use core privileges, where you define a core that if someone completes a certain level of training, they can just check in one box and they get everything that's included in that core. Or you can do any combination of the above. And there are some samples that are included in your documents, and there's no one way of doing this. I've seen privilege forms that are in many different ways that are put together. The one thing that you do have to have in order to meet your CMS regulations and in order to meet the accreditation standards of all the hospital accreditors is you do have to have criteria for requesting those privileges. So regardless of what type of privileging system you use, you do need to have criteria defined. Sometimes we have things that privileges that we call special privileges, or privileges that would be outside of a core. These would be privileges that would require additional skills or training, and this differs depending on when that technology was developed. An example would be robotic surgery. We have robotic surgery is just, the last 10 years is when we've really, seen that, really the last 5 is when it's really been ramping up. So the robotic surgery is not something that someone who did their residency training 15 years ago would have been trained to do. So this would be something that would be outside of the core, and it would be something that the person would be required to submit additional documentation of their training and experience for that specific procedure. Another example would be a conscious sedation. You may find that you may list conscious sedation in a procedure all on its own with its own criteria for being granted privileges to be able to do conscious sedation. There also are contractual considerations that may require things to be listed separately. For example, any cardiologist can read an EKG, but if somebody wants privileges to read EKGs and be the official interpreter for the facility, you may have an organization might have a contractual arrangement with maybe one group to be the official interpreters for their EKGs. So even if even though someone may be qualified and competent to read that EKG, they may not be able to have those privileges as an official EKG reader because they're not part of the contract. So you may also want to list procedures that require a contractual agreement outside of the core or listed as a special procedure. So some sample language, getting back to where we talked about that CMS regulation that says that you can't assume that someone can do every task privilege procedure that is specified, and you have to individually assess them. So there's some sample language that you can include on your privilege forms that says something like the procedures or privileges that are listed on this form reflect what most physicians with your specific training and experience can request and that this facility can support. And make sure that there's some language that says your ability to perform each procedure, privilege, or task is going to be assessed. And then if you have core forms, you can say something like, if you don't want to do something that's listed in this core, cross it off, an initial where you've crossed it off, or you may have I've seen privilege forms that have a place below where you can write it in, anything that you want to exclude. For example, you may have the family practice doctor who gets out of a residency training program is typically trained to do circumcisions. So circumcision may be something that would be part of a core. That would be a family practice core. But when a family practice doc is out of their training program and they go to work, they may find that, gosh, I haven't done a circumcision for 2 years or 4 years. I really don't want to do circumcision. So they may cross that off the list. And or they may write it below as something that's excluded, something that they just don't want to do. Also, if you're using the list where you just do the checkoff list or the laundry list, include something that says, please limit your request to those procedures or privileges that you're going to be performing at this facility. Sometimes we have these practitioners who have they may just be using our facility for occasional consultations, or if they have certain patients, but they may be doing 90% of their work at another facility, and they may do all of their big cases someplace else, and the smaller things might be only do smaller things at our facility. If that's the case, then they should limit their privileges only to those things that they want to do at your facility. Okay, let's switch gears again here and talk a little bit about red flags in the application process. Some examples of red flags are if someone loses their license or their DEA certificate is taken away from them. That would certainly be a problem, a red flag issue. And a red flag is something that just makes us stop and take a look at something a little bit closer. It doesn't necessarily always mean that there's a problem, but it could, it's a pretty good indication that there may be an issue. Loss of appointment or privileges. If somebody has their privileges taken away, that's usually a red flag, but there may be a time when it might not be. So for example, you might have a radiology group that works at a hospital, and the hospital determines that we're going to contract with a different radiology group. So everybody who is part of that group gets their privileges taken away because they're no longer, and their medical staff appointment taken away because they're no longer part of that contract. That would be an involuntary loss of appointment, but it would not necessarily be a problem because it's a contractual issue. If someone moves around a lot, frequent moves can also be considered a red flag because, you get established at a place, you buy a house, you get your kids enrolled in school, you really don't want to pick up and move. So if you see people that are moving around a lot, it may be an indication of a problem, with behavior issue or quality issues. So, it could just be that they just don't know, haven't found the right place that they want to live. So that would be evaluated on a case-by-case basis. Excessive professional liability judgments or settlements. A judgment is when a judge or a jury has determined that someone is negligent. That would be, and that they needed to pay. That is a judgment. A settlement is when there's money paid out in advance, and the case doesn't go to trial. Instead, just a monetary amount is paid to settle the case. So if there's an excessive number of professional liability judgments or settlements, this could be an indication of a red flag. So again, this has to be looked at on a case-by-case basis. There are some providers that are just you know, are in a higher risk, you know, spinal surgeons, obstetrics and gynecology, or the neurosurgeons. These people just have more medical malpractice lawsuits because they're in a higher risk area. So you have the medical staff has to look at that on a case-by-case basis. Information that's on the application differs from information that you get back from facilities. You know, you have different dates that come back. You get a verification letter back from a hospital that says we can't find any record they've ever been on staff here. You get negative responses from the peer references. If you can't find 3 people to say something good about you, you probably have a problem. So if there's, if you can't get 3 peer recommendations to give, you know, decent recommendations, then there may be a problem there. Adverse actions by a health plan due to quality care or professional conduct. Sometimes health plans, I've seen applications where they will ask if there's a health plan has taken any kind of action against you. Health plans also drop people from their provider panels, and that might be an issue as well. Also, we talked about unexplained gaps already, making sure that there's no unexplained gaps. All right, so let's look at different roles and responsibilities. Everybody's got a piece of this responsibility in this actions in the credentialing. And the first step is a credentialing expert. So that's the person who's verifying the credentials and pulling all that information together, getting it into a record that is easily reviewed and organized so that the person, the first level of review can start their work. And if you're a departmentalized medical staff, meaning you have like a department of surgery, department of medicine, and so forth, the next step is the department chair reviewing that documentation. Some bylaws that are for non-departmental medical staff may have a service chief, and you need to look at your bylaws to determine if the service chief has responsibility for reviewing credentials. Sometimes they do, sometimes they do not. But then that department chair or service chief would review the credentials file, that application, all the information that's received, and make a recommendation. If you have a credentials committee, many facilities do have a credentials committee. If you have a credentials committee, the next step would be the credentials committee reviewing and making a recommendation. The credentials committee or the department chair may also choose to do an interview with that applicant and determine, you know, follow up on any kind of issues that were identified in the credentialing application, or it just may be an informational interview for, you know, meeting with them and sharing information about the facility and asking that applicant about their, you know, how they plan to use the facility and what, you know, percentage of their practice and so forth it might be. Then the next step is the medical executive committee review and recommendation. Medical executive committee is typically the composed of leaders of the medical staff, and if you are a small facility, a critical access hospital, the medical staff as a whole may serve as a medical executive committee. So it may be the medical staff as a whole that meets. You may only have, you know, 5 active staff doctors on your staff, and they are the medical executive committee, or they act as a medical executive committee. So each of those does a review and a recommendation, and then the final approval is the governing bodies. So if you look at the steps in the process, if you look at steps 2 through 4, the department chair, the credentials committee, the MEC, all of these are reviewing information and making a recommendation. The governing body is the final authority, and they are the ones that approve the recommendation. So the medical staff makes a recommendation, the governing body approves or does not approve. So your medical staff is not granting privileges. Your medical staff is not granting appointment to the medical staff. It's only the governing body that can approve privileges and grant medical staff appointment. So when you're documenting things, your language that you include in your minutes and the various documents you have should reflect that. So you should be documenting recommendations made and taken during each step of the process, and you can include those either on in your medical staff minutes, or you can include them in a type of a form. And I'm going to show you just an example there. Get down to that. Okay, so this is an example of medical staff minutes. And so when you look at this, you can see that it's pretty complex. So I've seen minutes sometimes that just say the following were approved. Well, the medical staff does not approve. Like I said, they only make a recommendation. So what I always suggest to my clients is let's go back to your bylaws and let's look at what your bylaws say. And your bylaws will have some specific language of what each step of the process, what they're supposed to do, and so include the language in your minutes from your medical staff bylaws. So for example, the committee members reviewed the applications, the supporting documentation, the department chairman's recommendation, and information that was received during the credentialing privileging process. And based on that review, it's the committee's opinion that the following applicants meet the requirements for medical staff appointment and have documented appropriate education, training, competency, clinical judgment, professionalism, and health status to perform the privileges requested. But remember, those are those things that the CMS regs said that you were supposed to be looking at. Also, so then we say it was moved, seconded, and carried to recommend, if you go into the medical executive committee or whatever, approval of the you're recommending that the governing body approve those appointments and clinical privileges. So that's one way of doing it, making sure that you have it documented in the minutes. Now, some people like to have a recommendation and approval form. So the recommendation and approval form would be something like what you see on the next page, where it's just you put the practitioner's name and information, demographic information, and then the departmental chairman recommendation, privileges be granted, appointment be granted, additional privileges requested be granted, or a modification in privileges even. And then the department chairman checks that part off, and then the credentials committee would be the next recommendation, and then the medical executive committee and the governing body. So if you're going to use this type of form, there's no accreditation or regulatory requirements that say that you have to use this kind of a form. Some facilities like to use them just to have one form where they've got everything documented. It's okay that you can document this in your medical staff minutes the way we just talked about. You don't have to use this kind of a form. As a matter of fact, it's not, to me, it's one extra step. But I do get a lot of clients that like to use these type of forms, so I do offer an example here. But if you're going to use this type of form, what I suggest to you is that you make sure that you include language such as where it says the Credentials Committee representative, medical executive, staff executive committee representative, that you don't put chairman there, because if the chairman is not in attendance at the meeting and someone else is filling in for them, you would want to get that other person who's filling in to sign off on it. Because you don't want to have, says the Credentials Committee chair wasn't there, so then you get the Medical Executive Committee to sign it at the next meeting, and then the Credentials Committee chair signs it a month later. It doesn't look right when those dates are not in line, where the Credentials Committee chair is signing off after the Medical Executive Committee. The other thing that you can do is include in the date field just the date of the meeting rather than the date of the signature. So those are just some ways that you can document recommendations and actions. Okay, I think it is time for our commercial break.
Excellent. Thank you so much, ma'am. Now we're going to pause a brief moment before our Q&A to talk a little bit about symplr and how it relates to this topic. For this, I have brought in my colleague, Rachel Robinson. She is going to talk with you about these items.
Hi, as she mentioned, my name is Rachel, and I'm excited to show you just a few tools we have here at symplr to help you optimize the completion of the tasks and procedures mentioned by Kathy. Basically, keeping it in today's context of the discussion, we're going to look a little bit closer at the tools that relate to credentialing and privileging specifically, but feel free to send any questions to the email at the bottom of the screen. That's sales@symplr, sympl.com, and we'd be happy to address them that way. So diving a little bit in, we want to talk first about the credentialing modules available in Cactus. Next slide, please. So we have a web-based solution, which some of you may have seen Cactus in the past. It's definitely had quite a big update to the new system that we're using now. There's a new look and feel. We're also able to offer on-premise as well as SaaS, or service as a software, meaning hosted services to you as well. That means incremental releases don't have to be updated on your workstation. That takes some of the strain and the weight off of your IT department that might be tasked with updating that for you. We also have lots of new features to help improve automation, new flexible reporting, ways to monitor data, all kinds of things. Go to the next slide. So one of the main things we've added, and I think this is a big deal, is being able to understand a high-level view of what's happening in your data. So with the dashboards in Cactus, you can see a real-time representation of what's happening. So how many applicants do we have right now? Do we have any licenses that are coming up for expiration? The analysis she was talking about to help better understand those gaps in education and employment, we've created tools to help you see that in a quick visual representation like you see here on the screen. We've also added some checks into the system to help you be on top of things that you might be concerned about with an individual provider. So let's say I'm looking at Dr. Adams. When I open up his summary, Cactus will immediately tell me if he has a license that's expiring, insurance, boards, anything with an expiration date will show up in this notification section here. In addition to that, you'll notice it's letting me know that maybe another provider who's sponsoring, proctoring, or otherwise supervising Dr. Adams, maybe their status has changed and they're no longer active in the system. You also have alerts built in to keep you aware of what's happening with other aspects of the data. We've also made it very easy. We're kind of known for the ability to pull lots and lots of data out of Cactus. So pretty much anywhere you put data in, you can go back and pull it out. We do that now with painting. So notice I just highlight a couple of fields, make them green, use different filters to determine what I want my query to look like. Go to the next slide. And it's so easy to build an extract or a roster, or whatever data you need to pull out of Cactus with just a few clicks in the system. It's not just for reporting. I mean, I can take this data, turn it immediately into a PDF document, take it to Excel, do some additional editing. I can turn this into a Word document and do a mail merge and do mass emails to the providers about expirables and things like that in the system. I can also take the data and turn it into a Crystal report, we have actually a built-in reporting tool if you don't have Crystal as well. But it's important to also know that with the query, I can jumpstart a lot of processes that are important to credentialing. So from here, I could take a large group of providers that I found within Cactus. I could send them to our online apps to get the application process started. I could do some mass updates to their credentialing files to track that committee progress as it happens. I could also do some things like check the ABMS, NPDB, and also do OIG sweeps, all kinds of other things directly from the query to get the data moving along for that provider. So with that, you have a series of documents, reports that come standard with Cactus, but now you can also create your own packets profiles. So with that in Cactus, just a simple couple clicks, you go and you can run the different items that you have saved. Go to the next slide. I want to talk a little bit about packets because it's new. So every once in a while, you may need to send out maybe a peer reference letter or some sort of application packet. And you've got that nice email set up to go out, but you may want to also include a couple of PDF documents, maybe something the provider signed that you'd also need to display. Go ahead and go to the next slide. With a packet, I can actually send out an automated email, and I can include along with that the PDF attachments that are relevant to the topic. Next slide. Now, in addition to being able to send those out manually, there's a tool that you can add to your system called the scheduler. So with the scheduler, any of those expirable notifications or letters that need to go out, maybe there's a report that needs to go to the CIO, any of that I can actually set on a schedule. So that means I don't need to be in the office when I run this. I can actually be outside the building. If it's anything where maybe we're looking at expirables, especially, you want to put those on 30, 60, 90 days, so the alerts are going out to the providers automatically with no interference required from the staff. We've also built some tools to help you optimize the things that you're doing in the system to stay on top of work. So I can create a task, relate it to a provider, or relate it to myself, just something for me to remind myself to do within the system. I can also assign tasks to other people for follow-up. In addition to that, we've added some more things to kind of create a more individual user experience. So all throughout Cactus, there's something called user preferencing that you'll see, where you can change a screen, it'll remember how you want to see it, and then we've added things like shortcuts and the pins you see highlighted here. If it's the end of the day and I know I've got to look at Barbara Hannah's sanctions, I know it's something I need to pay attention to, but I've got to run, I can pin it to my desktop, come back to it later. So next I'm going to move on to privileging and just talking about some of the tools we have available to help optimize the privileging process. So a couple things to know. With Cactus, there's two different privileging modes that you can use. You can actually use Cactus and manually input your own privilege context. You can continue to use privileging the way you already do, but there's also a new option that we want to make sure you know about. It's our Enhanced Cactus Privilege Plus. The idea behind that is we're trying to do some of the work for you, and I'll do a little bit more explanation into all that, but along with that feature, you'll have real-time privilege lookup. So envision a nurse at the floor needing to see maybe something that's been added to a provider's privilege, maybe there's a new limitation. That information comes directly from Cactus, so it's real time for them when they look it up. Corporate privileging means instead of having just a kind of whirlwind, you can create a little bit more organization and say, here are all the privileges that are going to be available at all of our facilities, and then you can set some rights to say, you know, maybe I want this facility to have control, but not this one. And also, with the privileging that we're editing in Cactus, you can actually save different versions of the privileged text, which is all going to be related to our library, which is the next slide. So, big deal here. We've got about 9,600 different delineated privileges, over 256 specialties. The idea is we're trying to bring the most comprehensive library to you and put it in your hands. You just pull down what you need from the library to use within your system, and then you can edit it to make sure it meets your bylaws and other standards. We have a research team that works to update the library on a regular basis. They're looking at different medical schools and vendor device manufacturers to find out exactly what needs to be there. Then those privileges are automatically linked to the CPT, ICD, and 9 and 10 codes. And we know the 11 codes are going to be huge, so we're going to make sure that data is already in your system with our privileging tool. That also ties directly into our quality products, by the way. So back to the PowerPoint.
So sorry, I am having technical difficulties on my end. Rachel, if you want to keep talking, PowerPoint quit unexpectedly on me. I will have it open in a moment.
Sure. So the next things we're going to talk about are really related to the privileging process. Keep in mind, we've kind of briefly talked about features that we have, like online applications that you can use. The online application process means that you start on an electronic level with that provider. They get an email telling them where to go and fill out all of their information as it relates to their application. That includes the privileging, by the way. So they can fill out their privilege request form, fill out their application electronically. That data can be fed back into your system. And now that we have the screen back up, this is kind of an example of how some of that corporate privileging is set up. I'm on the corporate level here, and I can come here and set different settings for the other entities in the system. I can determine whether or not they'll be able to have access to the library. I can also determine whether or not, you know, a certain entity will have control over the privileging. Thanks, Callie. Let's go to the next slide. To find privileges and bring them down from the library, there's just a simple search from within your Cactus system. You can bring down individual privileges, or you can bring down an entire practice area. Go to the next one. This is some of that drafting I was talking about. So you can bring it down, but then maybe you decide that the description needs to be a little bit different to meet your bylaws. You can do that, and you can also understand a sort of a representation of how this privilege relates to everywhere in the organization. Instead of having to type this information over and over again, there's one privilege, and then there's a global sort of update if I make a change to it here. You can see at the bottom where it's connected to other practice areas. So when I make a change, I know it's going to also affect cardiovascular medicine. Go to our next one. And we also provide, especially for that breakdown between core and special, we know that's really important. So you can do that, but we also provide the threshold criteria for the special privileges. And this is a good example of the rich text editor that we include along with that privileging library that lets you have a little bit more control over how that looks, again, helping you make sure it adheres to your bylaws. Go one more. Okay, so that's pretty much all I want to talk about on the privileging aspect of it, but I do want to let you know our goal is to help you have a full circle provider management solution. So we really focus on the credentialing and privileging, but that privileging feeds directly into our quality and peer review products. Now the goal of those, of course, is to help you demonstrate how your bylaws, policies, and procedures are being followed on a regular basis. Tools like Committee Manager will help you with tracking the review and approval process online. So think about that process mentioned by Kathy, but envision it as something that a provider could participate in outside of the meeting if necessary. They could access it on an iPad, outside of the system. The whole idea is to kind of help keep this cycle moving in an automated electronic manner. For any questions, again, email us sales@symplr.com, and I'd be more than happy to elaborate further.
Thank you so much, Rachel, and thank you, Ms. Kathy. We have run long today, and we would like to apologize for that. In order to combat that, we will reach out to you if you've submitted your questions via the question portal. I will work on getting back to you with those answers. If you do have any others that come up, please email us at communications@symplr.com. Again, that is communications@symplr.com. I would also like to reiterate that we will be sending out download information and viewing information for today's recorded webinar. We will send that out via an email from communications@symplr.com, so please make sure to add us to your address book in order to receive those emails. We will also be sending along your NAMS certificate in a separate email from that same email address. So again, please add communications@symplr.com to your address book. Ms. Kathy, is there anything you would like to say in closing to our audience?
Just thank you for listening, and if you do have any questions, I'm sorry we ran out of time, but I will answer any questions that you send to me. I'm happy to do that. You do have my contact information, or if you send them to Callie, they'll also forward them to me, and just want to thank you all for attending, and look forward to the next session that we do.
All right, thank you so much, ma'am. And everyone, please keep an eye out on symplr.com as we announce future webcasts with Ms. Kathy and other guest speakers. You can find all that information at www.symplr.com in our resource library. Again, thank you for joining us today, and we hope you enjoy the rest of your day. Bye.